Thank you, Jeff. I'll ask the speakers to please come up for the panel discussion. If you have questions or comments, please come to one of the microphones and identify yourself and make your question or comment. That way it can be recorded in the proceedings of this meeting. And as the speakers are coming up, I just have one brief comment. This is an incredibly novel opportunity in which we're combining science, policy, and strategy. And I think you all already know there's some themes emerging. One is the incredible opportunities we have in comparative oncology, but also what are the gaps, what's holding us back. So we'll start with the gentleman here in the yellow. Thank you.
Robert Don NHLBI. It's a very unique opportunity because I was thinking about it, and maybe you'll know far better than I, but if you look at vertebrates, it seems like the human and the dog are the ones that tend to have more cancers. If you look at rhesus, which I'm familiar with, it's relatively rare, and I was really sort of surprised by your comment dealing with funding, because I think the dog's a phenomenal opportunity here. But I'm wondering why. You see more spontaneous tumors in the human. Is it just longevity, numbers, or is there a genetic component to this if you look at the dog and the human?
So, Justin actually has a crazy theory about this. Oh, I'm sorry, wrong one? Oh, my book actually has a crazy theory about this, and it's about adaptation to the human environment. I mean, humans and dogs are uniquely adapted to dealing with humans in the human environment. And I think that kind of convergent evolution has led to them getting the similar kinds of diseases. I just want to say that is a bit of an out there hypothesis, but we have seen it over and over again. We see brain genes, synaptic signaling genes in cancer, and then we think that might the selection on behavior might have to do with both humans and dogs.
How about DNA repair mechanisms? Are there differences between dogs or similarities between dogs and humans? But if you look at the rhesus, the rhesus may be different.
I mean, I don't know in detail, but I believe that rhesus and humans have really similar DNA repair mechanisms.
Thank you.
Well, it is worthwhile saying Carlo Maley and a series of others, and maybe in that issue that is being published, has looked at, why don't whales ever get cancer, for example. So it's not size-based, it's not frameworks associated with that, and there's a whole group that have been working on the sort of vertebrate cancer conundrum, and again, I believe that's part of what he has in that volume that'll be coming out today.
To the other mic over here.
So first I would like to make a comment regarding this mucosal melanoma. So about 6-7 years ago, we also found a lot of MDM2 amplification and p50 deletion, so which are consistent. So the question I have is based on the panel presentation. So the mucosal melanoma seems like, based on your data, it's not like breed dependent, so it's independent of breed. However, for this osteosarcoma, it seems like a breed-dependent mutation. So does that mean mucosal melanoma is more environmental induced, not genetically, predisposed, or anything like? So.
Well, I don't know if the question is for me, and Matthew has a lot of data on mucosal melanomas as well. I mean, again, the human cutaneous melanoma data is just that. It's sun-exposed data. The TCGA data, for example, was almost 350 cases. None theoretically should have been mucosal. Again, there's, if anything, the environment, I would argue, on the mucosal side is going to be less of an issue, certainly, than one thinks in terms of cutaneous disease. So I'm not quite sure I know exactly what you're asking specifically in terms of the mutation spectrum, but I think mucosal melanomas, acromelanomas likely have a genetic component. An example that I'd just throw out there again is that, acral mucosal melanomas only represent 1 to 3% in humans in the U.S. population. They represent over 90% in the Korean population. So we've been working closely with investigators at Samsung Medical Center looking at variation on the human side, and certainly that's true of some other Asian populations as well, which would lead me again to argue that there's probably more genetic underpinning and something that might be looked at in that regard.
Hi, this is Xia Yinzhao from University of Georgia. Actually, I have a question about the tissue collection. I mean, so there's a lot of community practice clinics, and then they see different type of K-line tumors than, like a teaching hospital at the university. Because I think it's actually a great resource, because if you're looking for the human cancer, 90% of them are epithelial, like a breast, colon, lung, So I think this is more like a skin cancer, mammary tumor at the practice community center. So if we actually can, collecting those tumors, we probably can make a better argument for, a K-line cancer, actually, a better model for the human cancer, because people care about it. 90% of the human cancer are epithelial. So that's what I think we should utilize those resources.
And what's the question?
Just a comments. The question is that, I mean, is there any opportunity that your guys are going to organize collecting tumors from a community practice centers instead of a teaching hospital?
So when the CCOGC was established by comparative oncologists, a group of veterinary oncologists, human oncologists, veterinary pathologists, human pathologists, to initially address those cancers that were at that time considered the most comparative value, as in osteosarcoma, melanoma, and lymphoma. There is every expectation that that cohort can and probably should be expanded, and you're absolutely right. But the key thing about the CCOGC's decision-making process is that we have looked at private practitioners and veterinary referral centers. The key issue is not everybody wants to adhere strictly to the SOPs that are put into place to collect those samples. So when we initially looked at a variety of vet schools across the US, several vet schools don't, by definition, follow the SOPs that the CCOGC's Tissue Collection Committee felt was the most appropriate for procurement. So they kind of self-excluded. But I do think that now the opportunities are rising, there is every expectation that that will expand. But the whole concept of collecting by SOP has to be paramount at the top of the list.
Okay, the other thing is that, there's actually Europe, there's lots of mammary cancer research going on there. So is there any plans collaborating with Europe also on, on those?
We talk an awful lot with various people about how to expand it. So my suggestion would be contact the CCOGC administration, make the suggestion and start the conversation. That's probably the best thing to do.
Okay. So I have one more last question. So, I mean, everybody was talking about genetic studies, but I think in K-line cancer, based on our study, actually epigenetics is as important as genetics. And actually, I think, I don't have much data on this, but I think the microenvironment is probably more important in K-line cancer development than in human. Just when human get cancer, they are 70 years old. But when a dog get cancer, they are only 10 years old. So I think that in that way, it's reasonable that perhaps lung genetic factors is probably more important in the dog development. That's just my theory, but that's.
Thank you for the comments. Let's go back over to Dr. Tham.
Doug Tham from CSU. I guess I'd like to sort of bring this back to drug development for just a second, and bring up the issue of pharmacogenomics, and maybe you guys and Dan as well might want to comment on this. So, as veterinary clinical researchers, we get a question from potential sponsors all the time about, do you see breed-specific differences in tumor response? Do you see breed-specific differences in toxicity? Do you see breed-specific differences in PK parameters? And I guess knowing what you guys know now about the genetic landscape and your ability to do these sort of large-scale studies, is there an opportunity to integrate pharmacogenomic explorations into these proposed dog studies and maybe get an early sense about not necessarily tumor predictors of response, but host-based predictors of response vis-a-vis drug disposition and metabolism and things like that.
So my response and comment to that would be that a lot of the studies that I'm aware of, they're really driven by limited positions on where the decimal point is. And therefore, as I come back to saying that, regardless of what the clinical trial is and the investigation aims to achieve, most of my clinical colleagues will tell me that they are somewhat breed agnostic, and that the patient comes to the clinic, they don't determine necessarily which patients are going to get treated. It's somebody's pet. And therefore, the only way I can see a study going forward that is purely breed specific is for those clients to be compensated substantially for bringing those patients to a specific venue for treating. I think that's actually one of the good reasons why, when you think about the Morris Project focuses on 3,000 golden retrievers. Everything about those golden retrievers will be identified at some stage by hook or by crook during the life of their career, during their longevity, including those that develop malignancies, will be explored for when they develop a particular kind of cancer, what are they treated with? And their biological specimens will be collated. But that's a project that's going to span 15 years. And the dogs won't really start to develop malignancies for hopefully 5 to 6 more years. So the number of dogs in that particular cohort that will be available for those kind of questions and the time period could actually go down the road and beyond 2020. I think what we need now, and this is an issue that comes back to what we all spoke about, is we are really getting very good at identifying risk factors that are associated with those breeds of dogs that are highly predisposed to certain types of cancer. I think one of the major challenges that we have is we are so good at doing that that the breed clubs now respond and say, okay, so what do we do with that risk information? Is over the next 5, 10 years, I strongly suspect that the incidences of certain types of cancer in those high-risk breeds will start to decline because the breed clubs will be starting to reduce their incidences. So if we want to take full advantage of the power that the purebred dogs can offer for cancer, risk factor development, diagnosis, prognosis, we have to do it now, because if we don't do it now, in 5 to 10 years' time, maybe there aren't Scottish Terriers getting bladder cancer anymore. Maybe the golden retrievers are now not as predisposed to hemangiosarcoma and lymphoma because it's been carefully and educationally bred out of them. So now's the time to act.
I'll just add that certainly there are going to be opportunities as the same enzymes that are important in metabolizing drugs are important in metabolizing carcinogens. So I think there'll be chances to go forward on both fronts. Yes, sir.
Yeah, Carl Barrett, AstraZeneca. So I really enjoyed the session. It's great to see how much progress has been made. I forget who it was. One of you mentioned that your last bullet was that dogs could be very good models for molecular subtypes of human cancers. And that's kind of where I was coming from as I was listening to you. I was sort of struck by, I was looking for, TSC2 or ERCC mutations in bladder cancer or GNAQ mutations in melanoma, MYD88 in the lymphomas. None of that did you show that data? Is it too early to say those subtypes of human cancers, which are very much targetable, are not in these canine tumors, or is it just too early to say that? And the second question I have is, do you have any data for an ApoBec signature in these tumors, to the point about the etiology?
About the not finding the most prevalent human mutations in dogs, I think we need to do more breeds. Honestly, in our study, we did 2 breeds each for B cell and T cell, and would find 1 or 2 different subtypes. I think that the key is more breeds to find more subtypes.
Yeah, I think it's going to be, I don't doubt that if we're looking for tumor-specific genetic changes, we're going to have to look at multiple breeds, but the majority of dogs are not purebred that get cancer. And so I still think that there's going to be frameworks for looking at that are important. But in regards to the question of why don't we see some of the standard predisposing gene pathways, even if you look at the pathway level, it'll surprise me if just by doing another 20 dogs, we're going to see something very different. So I think they are getting at the same endpoint. There's still ERK reactivation if you look at Dan Gustafson works and others in melanoma, but they're getting at it from different pathways. And so maybe it's phosphatases or acting or some other aspects, but we're getting to the same point, but I think we're going to likely get there in a different way with at least some of the docs.
So I'll just come back to Matthew's comment about being breed agnostic. So I'm certainly breed agnostic. And that's because as a clinician, despite, and this is a question I guess to both Jessica and Jeff, my clinical intuition is consistent with Jeff's expression data. And that's that once you get osteosarcoma, you have osteosarcoma. It doesn't really matter what breed you are. With a very rare exception, does the breed influence any biological behavior? And it's a very subtle effect if it exists. So I'm interested that there are breed-associated changes that link to alterations that put you at risk. But then what seems to me happens, and here's the question, it seems to me that once you get cancer, then you get evolution and you have cancer. Doesn't matter how it started, you have cancer and you're going to treat it the same way. So if breed was such an important driver, I would expect us to treat every breed differently. And the reason we don't is because they're biologically really not different. There are some subtle influences that as you get more gray hair, you sort of pick out, but generally speaking, I'm not convinced that the breed-associated risk factors lead to biological events or to therapeutic breed-specific interventions.
Is that because of a lack of reagents that target some of the pathways that have been identified, or is that because really the final common pathway is exactly the same?
Well, I think that independent even therapy, the biology of the disease is not breed-associated. So I would say it's not because we haven't treated with the right KIT inhibitor or specific inhibitor. It's just that the biological basis of the disease is not influenced by the genes that cause the cancer to jump off the edge. And then as it falls and evolves, all of the things that make it bad are breed irrelevant. That's my clinician's perspective.
I would say that depends upon when you treat and what.
Yeah, so I think from what we know, so there may be, we'll learn more as we do things differently, but from what we know right now, breed is not an influencer of biology.
I guess my feeling is that we're not there yet. I think much as in human cancer, the goal in human cancer genetics is to be able to molecularly identify subtypes that are treated differently. But and the same thing would happen in dogs, and perhaps it won't be that boxers all get the same treatment, but most boxers will get the same treatment if they have the same molecular signatures.
And so again, so independent of treatment, we know, I think we are at a time where we can say we understand the biology of disease in breeds. I agree that we haven't treated them all differently, but the biology of the disease in breeds is not distinct enough for it to seem important. So it seems to me that it's great to sort of identify genes associated with risk, but it's unlikely in my mind that those genes are going to really trump the cancer evolution that then will occur.
I think that's closing a huge number of doors, though, to assume that we know. I mean, I think that we don't know. We simply, it's like looking for the keys under the lamppost. There's just so much we don't know. I think we can't make assumptions, and we should be very open-minded about the fact that any of our speakers might be wrong.
No, it's not to say you're wrong.
Easily be right.
No, I'm just saying there isn't evidence to say that it is a driving, and so I think from the cancer standpoint, it's interesting to me to say that cancer starts and then bad things happen, and what started that cancer from being bad is really not very closely connected to how you'll intervene down the line. So to say cancer evolves is not surprising.
No, that is true. Cancer evolves, but the fact that there might be drivers that push that evolution in some direction is something that we simply don't know. And I'm not arguing it is or it isn't. I'm just saying that if we are focused on saying we already know the answer and that's where we're going to go, we're going to miss a lot of really cool things and a lot of really important things. So I think we have to be very open-minded to saying, yes, cancer evolves, but there's a lot of things about that evolution we don't know.
Well, it's worth also making the point that something like an MD2 application versus P53 mutation may ultimately result in similar biology, but MD2 application may be targetable, whereas P53 loss currently is not even close.
So I was just going to add that I think there's always a problem in just looking for targeted regions. In that, when you think about what Jeff was talking about and Jessica was talking about, is I think this has to be more of an holistic approach for a much longer period of time, because it's okay saying there is a mutation in this gene X that we've looked at in 30, 40 dogs, but those 30, 40 dogs may have been of restricted genetic background. I think the key thing is to keep it as broad as possible for as long as possible to try and address where the breed is specific. So one example I can give is with hemangiosarcoma, for instance, if you are an Australian Shepherd, every single Australian Shepherd we have looked at is completely different to other breeds. And yet the Australian Shepherds that get treated seem to do really badly. But the question is that because they don't become clinically manifested until later in the course of the disease than perhaps other breeds? Golden Retrievers behave very differently in their constitutional genomic organization when they have histiocytic malignancies than do all of the breeds. So there's something different about them. What we don't know is at what course in the disease are they when these cancers become to a stage where they end up in a clinic. So my prediction is that if we can, and this is just my personal opinion, the sooner we can diagnose some of these cancers in dogs, the sooner we get more of a picture of what the early stage disease is like. And that's where we start to identify some of the more pertinent changes.
Matthew, do you have a proposal on how we figure out why the Australian Shepherds are different? Because I just made a discovery with the gliomas in that for some reason French Bulldogs do not respond at all to the therapy that every other breed that I've treated has responded to. And as you know, I mean, I'm treating brachycephalic breeds, so it's not a... Certainly, I'm sorry. I just didn't want to miss this because I think it's really important. I've only treated 7, but I treated 3 earlier this year. And when I went back and I looked retrospectively at the other Frenchies that I treated, none of them lived beyond 61 days, despite getting very aggressive therapy. And so there is something different about the Frenchies that makes them different from the Bostons, Boxers, other Bulldogs. Yeah. And so, and my question is, how do we go about figuring out why these guys are different, similar to the Australian Shepherds?
So that comes back to what we're doing with Australian Shepherds, which is what we're also doing with gliomas, is we do what we call 360 genomic profiling. So basically, you just have to lay the cards on the table and say, what's the best hand to play? Is every breed potentially has a different hand to play, but until you can identify the joker in the pack, we really don't know. But you will only find the joker by laying the entire deck on the stack.
I'll send you the tissue.
Yeah, fine. Send the tissue.
We're running short on time here. Can we take one more question, comment?
So I want to come back. I mean, it's a fascinating discussion, but I want to come back to clinical studies in terms of, there are a couple of allusions to, or several people referred to combination therapy, and certainly with targeted therapy, I think we all understand now that we're not going to find a Gleevec that cures solid tumors. We need to use combination therapies. So my question is, and I think, Jeff, you even mentioned trying to move to combination therapies. So my question is, given the minimal amount I know about dogs, being a medical oncologist, not a veterinary oncologist, one of the things that potentially seems to me might be useful is the fact that tumors in dogs tend to evolve quicker than in humans, just like they age faster. So is there any data yet on trying to use studies of targeted therapies in companion animals to identify mechanisms of resistance that we could then, that would give us an idea of combinations we might want to try earlier rather than later based on looking, because I would assume resistance would evolve quicker in dogs than in humans. Do we know that? Has anyone begun to look at that?
I would either pass that to Debbie or open it to the floor, where there are people better qualified to answer that question.
I was just going to say we don't have those answers yet. We need
that
to
that might be something we ought to be looking at, because that takes us a long time to get to rational combinations based on resistance. And if we could get hypotheses in targeted studies in dogs, it would really help, I think.
I will comment that breeds are giving us an opportunity for screening and early intervention. We've actually launched one of these studies in bladder cancer in dogs, and we are definitely finding it early, and when we find it early, it is more responsive to therapy. So I think this is a great opportunity for being able to try to treat the earlier stages of the disease and intervene before the dog even has any clinical signs and before the dog's been exposed to other therapies. So I think there's one more comment, and then we really need to close.
Cheryl's right here.
On that, because Doug's actually looked at the outgrowth of mutations associated with treatments of dogs with basically he's looked at the outgrowth of mutations that confer resistance to small molecule inhibitors associated with KIT mutations, and they haven't been what we've been expecting. I don't know if Doug's there and he can comment on that.
So I think we can't comment on the timeline, you know, because these are in vitro studies about whether the timeline of resistance acquisition is any different in vivo or in vitro. But we certainly have identified a group of mutations that seem to confer resistance to certain kinase inhibitors. And again, sort of similar to the stories that have been told elsewhere here, despite the fact that the exact mutations are actually different from what we observe or what we expected to observe based on the human experience, the final common result was actually the same based on modeling prediction. So a change in the binding pocket that excludes the drug. That's an end of one example, but actually one of the studies, the study that Jeff and we are planning, one of the aims of that study is actually to clonally evolve a series of canine melanomas to be resistant to BRAF and MEK inhibitors, MEK inhibitors and PI3 kinase inhibitors, and actually determine whether the mechanisms of resistance that are required there are similar or not. That can inform subsequent studies down the line. So we're working on it.
This has been an outstanding discussion, and I'd love for it to continue on, but I think I'm supposed to send you all for lunch so we can meet back here right at 1 o'clock. Thank you very much.